Hello, everyone. I'm Dr. Jim Simon, and this is the second part of my two-part lecture on menopause. This part, we're going to talk about the impact of menopause on sexual function and how to increase sexual desire. The most common complaint beyond pain, which we covered in part one, the most common complaint a sexual complaint in menopausal women. These are my disclosures. I've shown you them previously, and they haven't changed. So the objectives of this lecture are to demonstrate that hypoactive sexual desire disorder, sometimes referred to as pathologic low libido or decreased libido, is a serious and oftentimes underdiagnosed and undertreated condition. It affects approximately 1/3 of US women at some point in their lives. We're focused on those menopausal women, and the goals of this lecture are to provide the attendee with an improved understanding of and practical skills to treat hypoactive sexual desire disorder, whether in premenopausal women or our focus here, postmenopausal women. Hopefully, this lecture will give you the tools to assess and examine those women, prescribe FDA-approved or off-label treatments known to increase sexual desire, to restore normal function, and better quality of sexual life. I would be remiss in suggesting that there are medical treatments for low sexual desire which work on anyone and everyone. This is clearly erroneous. There are many contributors to sexual desire problems, and they are largely brought into focus in this pie chart. For example, interpersonal relationship is critically important. You cannot fix a bad marriage or a bad relationship by giving a woman treatment for her vulvar and vaginal atrophy or medication to increase sexual desire, unless the bad relationship was actually caused by the low sexual desire and you, the practitioner, are removing a barrier to restoring desire and improving the relationship from that point of view. There are other contributors to low sexual desire, including expectations of a negative outcome due to a past history of disappointing sexual activity, lack of privacy or lack of emotional rapport between the partners, sexual trauma or physical trauma or negative emotions, shame, guilt, etc., as well as a knowledgeable and effective partner. So if the partner has erectile dysfunction, this is likely to contribute to an aberrant or a difficult interpersonal relationship, in one where the principal paradigm is normal heterosexual sex. I'll say parenthetically that while my commentary is largely focused on penetrative heterosexual relations, most of the medications I will refer to in this lecture for desire are not focused on either pre or postmenopausal women or any particular sexual orientation or definition, because these medications work largely in the central nervous system, which should be the same in each and every one of these cases. Let's talk about the partner for 1 second. And this is a little joke, but it's an apt way of thinking about sexual function in young men. So if you're dealing with a woman who has low sexual desire, regardless of where she is in her reproductive life, it's important to know who her partner is, and if he is a male partner, where erectile function is important, we like to say when he's young, he has sex, try, and he will try weekly or 3 times a week. When he's middle-aged, he might try once a week or weekly. And when he's of older age, he may try weekly, but his erections may not be very good. And therefore we say weekly, W-E-A-K-L-Y. This algorithm, which is the Ishwish process of care for management of HSDD, or low sexual desire with distress in women, is a free download from the Mayo Clinic's proceedings, was published in 2018. There's an update that is in press and should be available, but this one's from 2018, and it, like other algorithms, can easily be followed to provide good care for women with HSDD. Women do want to be sexually active, and many of them are even into their 90s. This is a large random dialing survey of women 18 to 94, 2,000 of them, showing that women 60 to 94 years of age, 20% of them are still sexually active. This other survey, a little older, from Stacy Lindau of the University of Chicago, looked at the impact of health on sexual activity. And for those individuals that said that they were in excellent or very good health, high percentages of them, as many as 40% of women 81 to 85, were in fact still sexually active. But when there is a sexual disorder, whether it be desire, pain, i.e. dyspareunia, or orgasmic, there are downstream effects or collateral damage, if you will, from them. So a woman with low sexual desire may have arousal disorder and orgasmic dysfunction as well. A woman with pain may not wish to engage, and so may not have desire, arousal, or orgasm. Let's just say that if it hurts, you are unlikely to do it. Ask yourself, when was the last time you put your hand on a hot stove on purpose? And the answer is never, because you know it's going to cause pain. Similarly, women who have painful sex, except in rare instances, are going to be unlikely to engage in sexual activity if it's going to cause them pain. Patients believe that we, the healthcare providers, are unconcerned. And in this survey, you can see that patients have multiple concerns about our interest in their sexual activity and their experience in trying to get care for their sexual problems, where there are many patient experiences occurring in high percentages where they felt neglected, where the physician did not want to hear about their problem, where the physician did not give them a diagnosis, where the physician did not thoroughly examine them, or they didn't follow up on the patient's sexual complaints. We, the practitioners, we have our own set of barriers. We don't want to open a can of worms, and we have a lot of time constraints on our interactions with patients. So we too have our own barriers. So between her barriers in asking and our barriers in wanting to engage on the subject of sexual function, there's frequently a Mexican standoff, or no interest or no progress on this problem at all, as it ends up at the bottom of the list of other problems, and then time runs out. If you look at data from large surveys, this from the so-called Preside survey, preside, standing for the prevalence of sexual problems associated with sexually related personal stress in American women, 31,581 American women. You can see that sexual desire problems here in the rectangles are the most common problem, and they rise to their zenith in women 50 to 59 years of age. Well, why, you ask, does it go down thereafter? Well, it really doesn't go down. This is desire problems and distress. The desire problems continue to go up as demonstrated here. This is the same data set, but the distress goes down so that the combination of desire and distress goes down. So, sexual desire is the most common sexual dysfunction. It peaks in the 50 to 59-year-old age range, goes down after that because distress from low desire goes down, not because low desire goes down. It continues to rise from women in their early 40s all the way up to the end of the survey, women over the age or equal to age 80. These are common problems. The average OBGYN sees about 8.4 women a week who have sexual problems, the most common one of which is low desire. Even primary care practitioners see about 4.5 patients a week with these problems. How do we understand the central nervous system regulation of desire and arousal? Well, it's primarily focused on dopamine. Dopamine is increased by testosterone, decreased by serotonin, and increased by the melanocortins. And when dopamine goes up, so does sexual desire. Estrogen and progesterone also have a secondary effect, increasing sexual desire. These are all evolutionarily derived. Recognize that a woman's sexual desire typically peaks around ovulation, as shown here. Here's human sexual desire, peaks right at or slightly after ovulation, giving time for the egg to leave the ovary to get fertilized by sperm, an evolutionary advantage that is shared with monkeys and rats. So our biologic side is related to hormones at mid-cycle. So what is HSDD? It is the persistent or recurrent deficiency or absence of sexual thoughts, fantasies, and or desire for sexual activity. It has to also cause personal distress or interpersonal difficulties like distress. And further, the low desire and distress can't be related or caused by some other disorder, drug, medication, or general medical condition. How do you make the diagnosis? There's a standardized screening test called the, appropriately, Decreased Sexual Desire Screener. It's a validated test. It's been published, and it only has 5 questions. The first 4 questions are answered yes or no, and they can be administered by the patient herself or by a medical assistant. But in each case, the patient has to say yes to the answer. So in the past, was your level of sexual desire or interest good and satisfying? And she has to say yes. Has there been a decrease in your level of sexual desire or interest? And she has to say yes. And is she bothered by her decreased level of sexual desire or interest? And she has to say yes. And then finally, would she like it fixed? would you like your level of sexual desire or interest to increase? And if she says yes to all of those, then you as a clinician need to do a little bit of querying to make sure that she doesn't have an otherwise other reason for her decreased sexual desire and distress. Is it related to her partner? Is it related to her relationship? Is it related to drugs or alcohol abuse? Is it related to a general medical condition? And these are all possible. And she has to say no to all of these. So yes to 1 through 4 and no to the others. If she says yes to 1 through 4 and no to the others, and you've ruled out these general illnesses and ruled out these general classes of medication known to adversely affect sexual desire, then she probably has HSDD or low sexual desire and distress. And for her, there are the following treatments. And I don't want to minimize psychotherapy. It's safe and effective, but does not address the biological understanding or drive for sexual activity. But I'm not indicating or even suggesting that it's not effective. It can be extremely effective and is often an important adjunct to the use of medications indicated here in the middle panel. Those medications include off-label medications like bupropion or testosterone in the US, or on-label medications like flibanserin or bremelanotide. But have no misconceptions. Many women will come to you or only come to you after they've tried a number of over-the-counter products with little or no documented benefit that haven't worked for her, as indicated here in the OTC internet offerings, which all work. They all work because placebo works. This is a very important slide from Andrea Bradford, really great study showing that more than 40% of women will have improvement, that is to say, statistically significant improvement on placebo when studied for HSDD or FSAD, female sexual arousal disorder. High placebo effect for all things, including everything she can get over the net or at the GNC store. Testosterone's been tried and used for low sexual desire for decades. It is a travesty that it is not available for women, in spite of the fact that there are so many available products for men. This review from Islam, Bell, Green, and Davis outlines the benefits of testosterone, not only for sexual desire, but for other metabolic benefits. We have the most data on a testosterone patch, which is not currently available. It's been studied in a number of different ways in both surgically menopausal women, here indicated as SM, surgically menopausal women, or NM, naturally menopausal women. And these are the primary endpoints for which it's been evaluated: satisfying sexual activity, how much more sex they're having; sexual desire, how much more desire for sex they're having; and how it's reduced their distress over having low sexual desire. These are 4 studies, 2 in naturally menopausal women, 2 in surgically menopausal women, demonstrating the benefit of this low-dose transdermal testosterone patch. In addition, Dr. Davis and colleagues published on the use of this testosterone product, and I have no reason to believe that other forms of testosterone wouldn't work in the same way, demonstrating that it's similarly efficacious in women not taking menopausal estrogen, with the proviso that those women are not having sexual pain. In this study, and each of the ones from the previous slide, testosterone was shown to increase desire, arousal, orgasm, sexual pleasure, to reduce sexual concerns, to increase sexual responsiveness, and to improve sexual self-image, and at the same time reducing PDS or distress. So this is a typical paradigm looking at the transdermal testosterone patch, which delivers 300 micrograms of testosterone per day, about the normal range for upper end of the normal range for a pre-menopausal woman with functioning ovaries. Now, there's a global testosterone consensus was delivered to the public in 2019 in 4 different journals published simultaneously, endocrine journal, a menopause, 2 different menopause journals, and a sexual medicine journal. And I'm happy to have been a part of this publication that lays out the importance of testosterone in both sexual health and other health benefits. But I'll remind everyone that unless you live in Australia, there are no approved products of testosterone for postmenopausal women. Here's a list of all of them for men in the US. You can see there's a bunch, and there are none whatsoever for women. So all the testosterone prescriptions for women are off-label, and this study, now several years old, published by Dr. Michael Snabes, demonstrates that as far back as 2006, there were 2 million prescriptions written for testosterone, not in their whole, but testosterone prescriptions for women, thought to be about 20% of all the prescriptions for branded male testosterone products were likely headed for women, as well as high percentages of the compounded products. Sharon Parrish and I and a group of others published a paper not terribly long ago, this was in 2021, on how to use testosterone in postmenopausal women. Not could you use it, not should you use it, but how do you do it? That's the focus. And in that paper, the question was, what's the testosterone level in blood you're shooting for? And this may be relevant for the basis of what we use in menopausal women. So recognize that really our youngest patients have a higher level of testosterone than even 30-year-olds and 40-year-olds. And recognize that while that difference looks pretty subtle, it's pretty different. And any of these can be targets for you in your attempt to replace testosterone in postmenopausal women. Like all endocrine hormones, there's a wide normal range for testosterone, and those that have too low levels have problems, and those that have too high levels have problems. I haven't seen too many too low levels after treatment, but I've seen plenty of women getting way too much testosterone, particularly from testosterone pellets or testosterone injections, neither of which were endorsed by ISHWISH in that how to use testosterone paper. I've seen some women with testosterone levels in the normal male range, and when they lose their hair or grow a full beard, as demonstrated in my face, they're not very happy. We demonstrated Dr. Kraft and I demonstrated that testosterone may normally have a bimodal distribution curve, whereby a little is beneficial, a little more is more beneficial, but too much more than the average range for premenopausal women actually reduces benefit. And that's shown for you here in the studies that we published on, showing that while 300 micrograms per day is in the normal production rate, as I showed you previously, as you get more than the normal range, you actually decrease efficacy as it relates to desire, as it relates to arousal, not for orgasm or pleasure, but also for sexual concerns and body image. All of these are lower on higher doses of testosterone than the dose that's recommended. Here are some therapeutic choices. I don't want to go too far over, but we recommend either a testosterone cream that can be ordered from Australia that's applied to the thigh and buttock, 5 milligrams of testosterone in this cream. It's available over the internet for you and your patients, or to use 1/10 the male dose of a product, and a product that is easily adaptable for use in women. And the one we chose was Testim, which is a brand name product of a testosterone gel, recognizing that a man uses one full tube of testosterone every day. And we recommended that women use 4 to 6 drops out of each tube on a daily basis. There's one small problem, and that is this product comes in 2 formats. Tubes come 30 in a box, like this, like this, like this, like this, or like this. But it also comes in sachets or ketchup packet-like containers, which cannot be resealed. Recognize that each of the tubes can be resealed after 4 to 6 drops have been dispensed, whereas these packets cannot be resealed. And if they're left open, the alcohol, which is the primary driver of testosterone through the skin, evaporates, and the gel becomes both more concentrated but less absorbed. This is the product from Australia, so-called Androfem, or sometimes called Androfeme. It comes in a big tube, use a syringe for dosing, usually half or 1 milliliter. It's compounded in olive oil, so it's very emollient and skin friendly, and it can be ordered over the internet from the Lawley Pharmaceutical Company, Lawley Pharmaceuticals, over the internet. Safety is the concern with testosterone. It's the one reason the FDA has failed to approve it for use in women. And this is despite the single longest study, which I was associated with, 48 months of treatment, more than 1,000 patient years of exposure, where the principal findings were a small weight gain of 1.7 kilograms, which over 48 months is not that different than normal age-related weight gain, a small increase in blood pressure, less than 2 millimeters of mercury, and there was an increase in the number of breast cancer cases, but that was exactly what would have been expected for women who are 4 years older, recognizing that the number one risk for breast cancer is age. There is potential for skin-to-skin transfer. So all of us, if we're using these products, should wash our hands carefully with soap and water after applying the therapy. Keep our skin covered, particularly when around small children or grandchildren, and when around other small pets, as pets may want to lick the recently applied product off your skin. Monitoring of testosterone should include repeat blood work every 3 to 6 weeks to make sure that you're not giving the patient too much, and to assess her for total testosterone rather than trying to measure free testosterone, which is extremely difficult at normal physiologic levels in women. One proviso, and that is that women with an SHBG level over the 170 mark seldom respond to testosterone treatment, as most of the testosterone that's administered gets bound up. I'll skip that. So here's testosterone, as I mentioned, feeding into dopamine, which feeds into desire. But there's also other places like melanocortins and other medications I've already mentioned that increase dopamine. And some of these are already in your medicine cabinet or that you use for other purposes. For example, the anti-anxiety agent Buspar or buspirone actually increases 5-hydroxytryptamine 1A, which is a partial agonist that increases sexual desire. Trazodone, often used as an antidepressant or sleep aid, does a similar thing to 5-HT1A, but also reduces 5-HT2A, and the combination increase sexual desire. And finally, vilazodone or Vibrid, which is an antidepressant, may also increase sexual desire in a similar way by increasing 5-HT1A. You probably are aware that bupropion, also known as Wellbutrin, has some data that shows an improved sexual response. It's documented to increase arousal and orgasm scores, although you'll not see desire here, which is the primary focus of our discussion. And the reason for that is it didn't reach statistical significance for desire in this small study of 35 subjects. I'll also point out that the average dose of bupropion used in this self-titration study was almost 400 milligrams. So high doses of bupropion necessary to increase arousal and orgasm scores. The highest level of information and the most robust data set is on flibanserin or ADDI. It's been studied in multiple trials, 3 of which were submitted to the FDA for approval. And the 3 that were submitted for FDA approval in pre-menopausal women are documented for you here, demonstrating an increase in sexual events and sexual desire and a decrease in sexually related distress, emphasizing again, compared to placebo, in pre-menopausal women. But there's also data in postmenopausal women, and that's demonstrated for you here, and it looks exactly the same. An increase in sexual events, sexual desire, and reduced sexual distress. So flibanserin can be used off-label for postmenopausal women. The data has been published, was published by me and a cast of characters in 2014, so it's not new. And I will also point out that in Canada, it's approved for women up to age 60. So ADDI is approved, or flibanserin is approved for postmenopausal women up to age 60. Many of you may remember that there was a very restrictive label for flibanserin. It came out in 2015 when the product was first approved. noting that you had to be certified to prescribe it, and it could never be prescribed with alcohol. And this is the boxed warning from that 2015 label. Since that time, we did 3 separate studies documenting safety with alcohol if they're given separately. That is to say, women can drink their alcohol and take their Addy at bedtime, or women can take their Addy at bedtime, but not their alcohol up to 2 hours before bedtime, and it can all be done safely and without added certification or prescriptive authority. And that's reflected in the October 2019 label that says Addy and alcohol together close in time increases the risk for hypotension and syncope, but counsel patients that they can consume alcohol up to 2 hours or 1 or 2 alcoholic drinks before taking Addy at bedtime. And if they are drinking when they're going to bed, they should just skip their Addy dose that night and resume the next day. And this, there was concern about Addy and dizziness, which was proven to be safe in this study, demonstrating that driving after doses of Addy the night before was actually improved compared to placebo or compared to an antihistamine called zopiclone. And another benefit of Addy, which might be of interest to some of our patients who are taking it for low sexual desire, is it caused significant weight loss in both pre and in the panel B postmenopausal women. So those led to the approval of Addy in naturally postmenopausal women less than age 60 in Canada. The other product we have that's FDA approved for premenopausal women is bremelanotide. And as I showed you, it's a melanocortin that increases dopamine. There's no reason to think that it wouldn't work in postmenopausal women, but the data on the existing product is non-existent, given its current dosage and delivery system, but there's no reason to think that it wouldn't work in postmenopausal women. How does it work? Bremelanotide binds to the melanocortin 4 receptor on the dopaminergic neurons, leading to increased dopamine into the cleft between the axon producing the dopamine and D1 or dopamine 1 receptors on the postsynaptic membrane, which lead to increased dopamine and dopaminergic effect, which stimulates sexual desire. Bremelanotide or Vyleesi comes in an auto-injector. It's not available in any form except by this one-use auto-injector, which is administered about an hour before anticipated sexual activity. It's a very small 29 gauge needle and a very small volume of bremelanotide, which are documented to increase sexual desire and reduce sexually related distress in these 2 identical FDA-approved trials. The age of the women in these trials is about 38 years, so not postmenopausal, and they had been suffering with low sexual desire and distress, or HSDD, for about 4 years, as indicated here. In each of these 2 trials, the injection increased their FSFI domain score for desire. So an increase in desire compared to matching placebo. And that was a highly statistically significant increase in desire and a highly statistically significant decrease in sexually related distress. In addition, sub-study endpoints included an increase in satisfaction, orgasm, lubrication, and arousal in both of these studies compared to placebo. The principal disadvantage of Vyleesi is it does cause gastrointestinal distress including nausea, with a very small risk of vomiting, but the incidence may be as high as 42%, maybe as high as 42% in individuals on their first dose. Other side effects include flushing, about 20%, and headache, about 10%. I'm often asked about marijuana's effect on sexual function, and I'll just say that the endocannabinoids, the active ingredients, or THC, tetrahydrocannabinol, THC, the active psychoactive ingredient in marijuana, actually has an impact on sexual function. It's been studied, and it's not at all clear that in women it has a major benefit, with the exception of reducing inhibition on similar to small amounts of alcohol. But in men, it may have an adverse effect on sexual function, increasing erectile dysfunction. And that's demonstrated here in this last study. I want to mention in closing sexual devices, recognizing that women need more stimulation for a longer duration to achieve orgasm as they get older. This is common also with men. So vibrators or other external stimulation in partnered sexual activity can be an important adjunct and can be recommended by us in the medical profession for just this purpose. And in these large surveys conducted by Debbie Herbenek, you can see that high percentages of women have incorporated the use of a vibrator in both their solo and partnered sexual activities. This cuts across heterosexual, lesbian, and bisexual women. And most of the individuals felt that their partners somewhat or strongly liked the fact that they used a vibrator in their partnered play because it made it easier for them to achieve orgasm. A couple of very quick comments about vibrators. 53% of women use them. They come in a variety of shapes and forms. Pay attention in your recommendations to patients that if they choose a battery-powered one, that those commonly need to have their batteries refreshed. If they want a plug-in one that requires electricity from the wall, that they typically cannot use them in the bathtub or in the whirlpool or in the shower due to electrical problems with electrocution. And many of them are not waterproof, even if they aren't associated with a plug-in type. So there are some nuances in choosing a vibrator and choosing its location for use. So in summary, sexual dysfunction amongst all women, but including menopausal women, is increasingly and is common. It affects about 1/3 of all women sometime during their lifetime. And as I've shown you, it's more prevalent in menopausal women. Most female sexual dysfunction is loss of desire, and it can be associated with personal or interpersonal distress. And when it is, we classify it as a disorder, a treatable disorder called hypoactive sexual desire disorder. I've given you a screening tool that's easily used in your offices or clinics, consisting of 5 questions, the DSDS, 4 yes and no questions, and 1 which requires a little explanation. There are treatments that are both off-label, and we have 2 on-label treatments for premenopausal women that work perfectly well in postmenopausal women, but are not FDA approved for it. And one is that is to say, Addie or flibanserin is approved in Canada for women up to age 60. The treatments don't work all the time in everyone. They work about 60% of the time. So setting proper expectations for your patients is critical. And let's face it, sexual function, including hypoactive sexual desire disorder, are multifactorial and consider both a biological and psychosocial approach where you can invite patients to go to couples therapy or individual therapy to help them with mindfulness and a better approach to overall sexual function. With that, I'll be quiet and let others ask and answer questions, but I want to thank you for your very kind attention, and I'm sorry for running over slightly with my commentary. Thank you very much.